Hey, everybody. Welcome back to the Pre-Hospital Paradigm Podcast. I'm Scott Wildenheim, and I'm going to remember to introduce my colleagues this time, which I may or may not just been getting razzed for in the preceding minutes here. So we got a Caleb Ferroni off to my left, and I've got a Dr. John Hill to my right here, and I even know my left and right today, which is fantastic. I think I did screw that up on another episode. And we got Roy Pace over there in the corner. So thanks for joining us, and have a little smorgasbord of things today. We've got this 1 hour ish, maybe a little longer, bonus material for July, and we were putting this together, and we had all this leftover material from previous episodes, right? And we had stuff we didn't talk about that we wanted to when some of the other docs were here or some of the other guests were here. And we just ran out of time, or we were just tired of talking, and basically just said to hell with this and left it for another day. Well, today's the day. So we've got the leftovers episode, and the first couple items here that are on the docket are things that are left over from the operational pharmacology. So that was with Dr. Spanner. We spent most of the time talking about ketamine in that episode, but there, of course, was a lot of...
we have other drugs in the drug box besides ketamine?
That's it. That's just one drug. If it can't be fixed with ketamine, I'm sure we've all seen that flow chart that everything ends with ketamine. Everything terminates in ketamine, right? Yeah, it turns out there is more than one drug in the drug box, and these are some of the leftovers we never got to, and a couple of things that in prep, if we're going to call what that was prep, in prep for this, a couple of other things that have come up in the meantime that weren't necessarily protocol when we talked about them on the episode. So the first thing on the list here is steroids, all right, is our methylprednisolone, our solumedrol, of course, the primary agent that we carry in the drug box. But I know in offline conversations with you that, and I know from my own experience QAing, my people, and I'm sure you guys can chime in here as well, probably underutilized and missed, and we really need to kind of stress its use. So who wants to take off with that? Because it's at the bottom of the protocol, I feel like people, I don't want to say ignore it, but maybe deprioritize it. I don't know if we forget about it, or we just don't feel like we get down to it. So
I think with solumedrol, I'll open with, we don't see the return on investment, right? So we were talking about drugs before this started, and we talk about D10, and we're able to correct that, and we see that return on investment. I think with solumedrol, we don't see the return on investment in the ambulance. So we're like, it's down the tree. I'm not going to see the return. I don't see the patients change. But once we leave the patient in the emergency department, they're going to see the change, and then that could actually prevent, possible admission or a re-entry of severe shortness of breath. So I think that's what maybe some of the mindsets of providers are. Do you agree?
Probably, because you're not going to see it right away. Solumedrol is going to take hours to be effective.
Peak, right?
Peak about 6, right? So you're not going to see it in the short time. Whether you have a long transport time, you're still not going to see it. However, what I tell my squads is that think of a typical patient call, shortness of breath, they've got COPD. We're going to give it for that shortness of breath and for the COPD exacerbation. They call you, it's been 3 days, they've tried everything they can at home, they've exhausted their resources. So they call you, you guys get there, you evaluate them, you give them a nebulizer, you start transporting, you get to the hospital in 20 minutes, and let's say that this is the perfect hospital visit. You get right in, you get to a bed. Get them tucked in, they're breathing okay, they're maybe on a little bit supplemental O2, we're finishing up a nebulizer. Then I get to go see them. And on a perfect visit, I'm going to be in there when you guys come in, I listen to your report, I evaluate the patient, I'm going to order solumedrol. So now they've called you, you've had a 5-10 minute drive to get to the patient, you pick the patient up, you're there for 5 to 10 minutes, you transport me in 20 minutes. I get to see them, I evaluate them, that takes 5 to 10 minutes. I then go back to my computer, I put in the order. Yep. The order gets validated by pharmacy. Nurse then pulls the med and then administers the med. We're going to be at least an hour on past the initial 911 call that they're going to get that medication.
In best case scenario.
In best case. This is all based on
right.
Looking at now, you guys, they call you, you get them, your evaluation time, transport time's the same, but now you're waiting on the wall for 3 hours. That's when you're actually going to see the improvement, is that 3 hour mark when you go to hand them off. And that's what we're seeing now in Northeastern Ohio, is these long wait times on the walls. But again, in the perfect order, we're at least an hour down the road before I get to see them. And honestly, if I can get them better and get them home, that's the whole plan. My goal and everyone's goal in the emergency department is to send people home. And I tell all my patients that, like, my goal is to send you home. If you have to stay and I want you to stay, you're pretty sick. You should probably be in the hospital. But you're not going to see that right away, that return on investment. However, what you are going to see is, though, if, let's say that they get sick and tired of waiting at the hospital, then they go home and they haven't had their steroid yet, they're going to call you back again.
That's true.
Or you offload them to the waiting room, they don't have their steroid back. Yeah. And that's really what's going to cover them. And that steroid you give is going to cover for 24 hours. And that's all they need for the next 24 hours. If I get to see them, I'm going to write them prednisone for home. We're going to do a burst, and they're going to go home with their steroid, and that's what they're going to take in 24 hours. And we've talked before, Ray, that it's the nebulizers help, but it's really the steroids that decrease hospitalization. They decrease your hospital stay. They decrease the level of care you need in the hospital. It's really the steroids that do a lot of the heavy lifting.
Do the lift, yeah.
But like you said, I mean, there's a difference between an acute fix and a chronic fix, and people don't necessarily go towards it because it's not an acute fix. It doesn't happen instantly, so we don't see the benefit, but there's a tremendous benefit. And you hit it right on the head. I think Dr. Yaski, Regina Yaski, last year did a pediatrics lecture, and she talked about that too, the pros and cons of giving it in the field versus in the ER for kids, and it was huge. Huge.
One of my favorite memes is, somebody holding up a Solumedrol vial, and they're like, "It's not going to work during transport," said the ambulance driver. Right? We are part of the global picture of patient care, and this isn't something that we can be skimping on. It is worth the time, and I think that just needs to be categorically said, right? It's worth it. It's worth the time, right? It's not. They're going to do it when they get to the hospital. They're going to do a lot of things. They may even redo a lot of things from a training.
We're going to be
for a training perspective. That doesn't mean that there's not a place at a hospital.
Correct.
And you guys focused really on the breathing perspective of that. In my mind, I think
that's your most common call. And the most common reason you guys are going to give steroids is going to be for
breathing. I don't disagree, but I think it's easier sell from the perspective of like an anaphylactic reaction, anaphylactic shock, where there's a much more marked difference in the their immune system's overactive. They've dumped all this histamine. They're bronchioconstricted. They're an absolute mess. We see the immediate action because we stab them with the relatively immediate action. We stab them with the epinephrine. Benadryl, oftentimes within our transport, we'll start seeing the benefits of that. But we haven't shut their immune system off, right? All we've done is blocked what the immune system has created, and we've blocked the critical thing that was trying to kill my patient as a result of the overactive immune system. That is a patient, you need to turn that off as soon as possible. We can't wait until you put your order set in, right? That extra hour, I think, is more critical in that patient, right, than the respiratory.
Yeah, I think it's fair to say if I take someone to the ER, how many nurses are working in the ER for how many beds? How many docs are in the ERs for how many patients? Are you getting a one-on-one patient experience? No, never. With an ambulance, you are, and guaranteed, I am with you until I transfer care. But you are my only project at the moment, right? And this isn't a mass casualty in most cases, but to get something that might take. Maybe you have 30 people in your ER waiting, and this patient who comes in might need Solumedrol, but like you said, there's a chain that you have to follow to get that medication. Why not do it when I'm one-on-one and just get it out of the way? Or
if they're better and you're dropping them off in the waiting room and you're offloading them, they might not be seen for hours.
Right.
And we do a lot to try to care for those patients when we're overloaded in the emergency department, to care for the patients out in the waiting room. We try really hard. One of the few things that it's really difficult to do is give them medication in the emergency in the waiting room of the emergency department, especially if it's going to be IV, because I have an IV in them, and then I got a patient with an IV waiting out in the waiting room, and there's a whole big discussion about leaving patients.
Appropriateness of that, sure.
Yeah.
Sure. I'll punt to you.
We're so focused on that hour. Well, there's other ambulances and under our medical direction, 30 to 45 minutes of transport time
easily
is pretty normal. So we could maybe even elongate that hour that med's been on board if they were aggressive, going down the tree, working their way up, giving duonabs, and then knowing, this patient's obviously could require Solu-Medrol, and they get it on board even earlier. And it's just beneficial for the patient. And not only an adult patient, and I'm glad, Caleb, you brought this up, this is also good for a pediatric patient, which was a change a year or two ago in our protocol. So we all need to remember that we can utilize this, at 1 per kilo to a max 125 milligrams in pediatric patients as well. It's going to be beneficial.
Yeah.
So.
The question I was actually going to run around the table here is, what if we're wrong, right? So I think a lot of trepidation, specifically from a new provider, is, we're hesitant to give something because we might be wrong, right? So what if a patient inadvertently gets methylpred, gets a Solu-Medrol that doesn't need it? So let's use the easy example of a pneumonia patient, right? So they're gurgly, they're horrible lung infection, and we get ahead of ourselves, and they get that out of hospital. How big of an issue is this going to be?
It's not an issue. Yeah. I mean, we're going to be treating the infection if that's what's going on there, and if you're treating the right patient. So you're going on a patient, they say they have COPD, they have asthma, you can hear wheezing. It might be a combination of, I'm a CHF exacerbation that was triggered by my pneumonia. I need to treat both of them. Yeah. The steroids are appropriate. Yeah. We're going to treat the infection with antibiotics, but you really need to get the steroids on board. Right. And they're going to get steroids during their stay in that case.
Correct. But you would, in a, again, perfect world, you would prioritize your antibiotics in that case over concurrently, or?
So I think we're going to talk about this later in the episode, but real life is different than taking a test, right?
Sure.
When you are taking a test, the answer is, what's the best choice of these answers? Sure. When in reality, you're going to do all of those things at the exact same time. So whether you're saying prioritizing antibiotics over steroids, antibiotics are going to go up first, and then 30 seconds later, I'm pushing the Solu-Medrol. Or honestly, in more reality, what's going to happen, I'm going to order all these things at once. Nurse is going to look at the orders and prioritize what she needs to do, get everything in the room, and then they're going to go to bedside, and he or her is going to establish an IV if it's not already there, draw blood cultures if we ordered them, and then probably going to be like, I can give an IV push of Solu-Medrol, or I can wait 30 minutes for my antibiotics to go.
Right.
They're going to pick the steroids to go first. I can push this. I hang my antibiotics. Now I'm out of the room. I can move on to my next patient of care. So the book answer is, I want to get antibiotics on board because I want to meet my deadlines for sepsis. I'm concerned about that and getting those, and they're more important. However, operationally, it makes a lot more sense from time management to push this drug now, flush, and then hook up my antibiotics.
And it's case dependent too. I know what you're saying, but this isn't a cardiac arrest.
No,
where you have to follow this. It's case dependent. So you're exactly right. I think to play off that, though, like you said, it's further down the protocol. It's not your albuterol Atrovent. Right. But remember, there is one more that lays a little deeper than that a lot of people forget, too, and that's mag sulfate.
And that's the mag, right? From a respiratory, in the respiratory case, sure.
So I think that's, if we're looking at this and saying we're at Solu-Medrol, I'm not going any deeper.
Well, the mag brings up a unique talking point, which is, I'll say it's unique because we've touched on this before in previous episodes, but it's,
why do I give it?
You have to know what your medical director's mindset on that agent is, right? You've got to interface with them. I know in my case, my doc has very low threshold. Yes, it's the bottom of the page, but if I said, look, the patient had already, taken an aerosol, hit their puffer 12 times before I got there. We'd given them one treatment. They laughed at that. I started the second treatment. I gave him mag. Yep. I know my doc is completely okay with that because that kind of reflects his care and things that that he personally believes. So it's really incumbent upon us as providers is to make sure we're interfacing with our docs. We're going to the CEs when we're coming out and doing these things. That's not an arbitrary thing, and you shouldn't just be sitting there silent in the back of the room waiting to be spoon-fed your ideals.
Enough. Right? If I'm worried about my treatment course, I'm going to call and ask
You can.
and verify my treatment course is the correct course of action, and don't be afraid of that phone call.
I think that is the subplot of this entire series here is
always that.
We
are
comment control.
There is some unfortunate stigma, at least in this area, about if it's not written down for me, it's either not important or I shouldn't do it, or that those boxes are gospel, and
no, the gospel's sitting on the phone on the other end, and if I need to know, then that's who I talk to in a lot of ways.
And here's again we're idealizing that. We're idealizing that conversation because everybody at this, including you, has gotten an a-hole on the other end, just follow your protocol or why don't you know this? And we can't let that demoralize us.
You don't ever take me wrong and think that I'm not saying don't know your protocols because you have an easy out. That's not the case.
That's not it, right. We shouldn't be bothering them unnecessarily, but if we have ideas, if we need to depart from that, coming from a guy that writes the thing, I often don't personally follow them. I use them as a set of bookends, right? Yes. I know what my treatment range is. I've interfaced with my doctor. I know what his expectations are, and how I can mold those. And when I slightly go off script or something, there's a really clear path that I'm putting in that narrative, not just I did a thing. Right. Yeah. I did a thing.
This is why, and this is what happened.
Here's what I was seeing. Here's why I was thinking. Even if I'm wrong, I know in the case of my doc, it's like, I don't like that. I understand what you were doing, though.
Yeah.
Right.
Oh, yeah.
Next time.
Yep.
Explain me your thought process into why you were doing that, and if it makes medical sense. Yeah, I get that.
Right.
Hindsight's always 20/20, right? I've got 3 days of data to look back to see what actually happened. Yeah, we guessed wrong, but because of these things, I thought this. That's a reasonable conclusion to make. Yeah. And we've all been wrong.
Oh, yeah. Or you were just wrong. Yeah. I understand how you got there, but, I need you to tweak that next time. And that's okay. I shouldn't be upset with that.
That's a great point for us to come in and say, okay, I see where you're going. This is where you went wrong. Let's talk about this so that we can get better.
And then other than blatantly missing things, I think when we QC charts as a whole, often we put that. Like, I understand your path here. In the future, look at this. Maybe this will help you.
Or this is how you differentiate A from B.
Correct. And I think just to go along with the breathing thing real quick, when we're talking about albuterol Atrovent, one thing that I've been talked to before and I've been asked questions is I've given albuterol, and now I'm hearing wheezing. That's a good thing.
Yes.
That's you've loosened them up now that they can wheeze. Right. And I think we might have talked about that before, but don't be afraid of that. And also that albuterol works one way and Atrovent works another, because I've also had people say, well, I don't use the Atrovent because they cough a lot when I give it. Yeah.
Is anybody here ever, going back to a case that was QA'd, right? I had a provider that was, the patient was essentially normotensive, and they were concerned about making the patient hypotensive with the MAG, right? And it's certainly never been my experience with 2 grams of MAG that I've made any clinically significant dent in anybody's blood pressure. I have one colleague that, I remember a story that they were on continuous MAG for eclampsia. Correct. Not surprisingly, tanked their pressure, but got it right back with a fluid bolus, and it was fine as a transport situation. But my QA to them was, hey, the 2 grams, as long as you're not already hypotensive, you really shouldn't be all that concerned, right? Most of these patients are going to be tachycardic and hypertensive because they can't breathe, right? 100%. So, if you start at, even if you bring it down 20, 30 points, if you started at 160 or 170, right? Then they're normotensive, right?
But also remember, we're not treating hypertension.
In that case,
it's secondary, but don't put that in your book of cards to say that, I could do this for the hypertensive stroke, because remember that's, again, I think we'll talk about it, but we want that hypertension
for the stroke. We talked about that.
I think we've talked about that before.
Yeah. And if you don't know what we're talking about, go look at the last bonus episode.
Which might be a good time for you to plug the website again, and then the changes you've made to it, because recently at ConEds, I've been showing people, go to this website, and I pull it up and I show them, and they're like, whoa, this is cool.
Turns out there's a
there's a place for that now.
There's a catch-all for that, right? Yeah. And that catch-all for all of that foam or that free open access medical education that UH puts out, that's the emails that you ignore, right? That's the medical director minutes that has good content in it. Pharmacy Friday, which again has good content in it. But we understand that you may not want that necessarily forced down your gullet, and you might not read it right then. You really want that kind of on demand, and that was kind of the point of the prehospitalparadigm.com. So, of course, it started off as really just a landing spot for this podcast, so we can put the audio, the video, do the show notes, do some other stuff that we couldn't really do in the EMS.org proper website, and I don't know it really belongs there proper.
No, I don't think it does.
So this is kind of the educational component of this that we've stood up on the backside. It's linked to this. But in addition to all the podcast stuff, it's now grown to include all that medical director minutes, and those are all archived by month, and you can go back and see who the doc was and what their message was over the entirety of the month. The Pharmacy Friday, again, same thing. You can go back. That's divvied up by drug. So if you want to read everything on
whoever's putting it together, you're doing a great job.
His framework.
We test it. They put it together.
We're the tester.
We're the test.
You're the QA.
Yeah.
I barely know how to use a web browser.
There's one set of sites you can get to religiously, though, right?
UHEMS.org.
There it is. Yeah, right.
And on the website, if you don't even know what you're looking for, don't know where to look, there's search functions too. So type in Solumedrol, type in whatever you want to look for, and
I'll tell you, much like geocaching, you can find hidden secrets in there. It's pretty fun. I found a few.
Oh dear. Just stay off the dark web, brother. That actually kind of brings up a nice little sub point there, which is new providers, specifically new providers, are in a good place in medicine. Stuff that we had to know because there was no immediate reference available, right? You're just a Google search away from, getting yourself in the right.
Oh, absolutely.
Right. The first time I had an Exelon overdose, I'm like, I've seen this. I don't know what the hell this does.
Yep.
I'm in the elevator riding down out of the nursing home. What's this do, right? You walk into the ED.
You heard of that med? Yeah.
In a minute, I have.
And that's okay. I mean, that is necessary because of the volume of information that's out there.
To a point, yes, I agree. Also, to a point, once you become a licensed, certified paramedic or whatever, yes, there's no cheat codes now, right? We can cheat all we want and make it work for our patients. But before, when you're getting ready to sit down for that test, you better be studying. You can't cheat at registry.
But here's the thing.
You can't cheat at registry, and you need to know all that stuff that's in registry to do your job.
Correct. That's core knowledge.
Once you have core knowledge, you can't cheat. And I like telling people that in the squad. Use your Google phone.
And the other point to that is we give you a cheat sheet going into paramedic school. It's called the curriculum. Yeah. It's going to tell you exactly everything you need to know coming out of that. Here. It's in the curriculum, right? Yeah. That was going back to my paramedic programs. The thing I hated the most is I had to write down the curriculum. We had to write all the curriculum out and then write notes on all of it. I hate it. I never did it. Somehow I still passed.
Yeah, you did.
Both my instructors are no longer, so they've since passed. So. I didn't do it.
He's a lot older than he thinks.
I'm not that old. Old enough to know better, still too young to care, right?
You had the Brady book version 1?
No.
0.05.
No. It was not a stone tablet. So we talked about the steroids and got off on a few other little tangents there. Circling back to some leftovers, on the note here is the dextrose concentrations, and this has been a point of humor for us, right? Is that we have the 5%, we have the 10%. For those of us that have been around long enough, we remember the 50% concentration may even still periodically show its head,
and we use all the time in the hospital.
Wind up in your drug box, but You want to talk about the 5 versus 10%,
Sure.
and where a provider can get into trouble and some mindsets there?
So one of the things that we did was we changed how many we carry, right? So historically, we used to have 2 D50s in the box, and then we switched D50 out for D10. So we have 2 bags, 250 milliliter bags of D10 in the bottom of the drug box. And we also have a 100 ml bag of D5, which we mix drugs in because we moved away from normal saline. Correct. We've added an additional 100 ml bag of D5 so that, if you mix an epi push dose presser, which we'll get into in a little bit, or, possibly a drip, you still have another use out of that drug box because it was just low hanging fruit. It was very easy to adapt it. And add both. So if you're a provider, you're going in the bottom of the box, you're like, I have these 2 bags. It just says dextrose. One's going to say 5%, one's going to say 10%. So I always try to tell everybody, if it's the heavier bag or it's the bigger bag, that's what I'm treating my diabetic with. If it's a lighter, thinner bag, that's the one we're going to mix drugs in. So the smaller one. We have had providers try to treat low blood sugar with bags of D5.
D5, right?
Just, not beneficial. Patient's still unresponsive.
Generally not enough.
It's not enough to really make a change for that patient that's in need. And I think we've caught those. We've done some education in the emergency departments, but it just boils down to looking at the label. Do I have D10 in my hand and I'm trying to treat a diabetic, or do I have D5 and I'm trying to mix some drugs?
In the hospital, you may see them use the hospital use 5% to maintain, right? And we are often
for maintenance fluids. Correct. However, if we have a patient that's persistently hypoglycemic, though, our go-to is going to be D10 also. So we do use it in the hospital too. And
some of the benefits of D10, compared to why did we go away from,
D50.
D50, right? UH endocrinology was really pushing that. It's essentially more readily absorbed into the body at a safer rate. It's thinner. We can start an IV even if you have a smaller gauge IV that, you're trying to push pancake syrup through that syringe in the old days with D50, and you're worried about infiltrating a vein, right? Because it's necrotic. We don't want to do that. So moving away from that to a thinner product is so much easier to use, and it'll work from, the newborn infant to the geriatric patient. So that was another thing too that was problematic with D50 that I don't think a lot of providers still talk about is if I have that pediatric patient now, I have to cut it, or I have to have
D25,
I have to have D25, or I have to make it now. So it's just D50 was just super problematic in multiple areas. We had discussions when we did the protocol development with UH endocrinology. We felt this was a safer route to move to. It's easily more readily absorbed, and it helps essentially bring that patient out of that hypoglycemic event, and you start to see them wake up easier. We can check their blood sugar, and they're more at a normal blood sugar level for them when they're coming around in their ANO times 4 versus I give this huge syringe of pancake syrup and now you're at 350. Yep. And it's like, okay, I took them from hypoglycemia to hyperglycemia.
We saw a lot of sign-offs cease after that switch, too. A lot of people were waking up quick and then saying, I don't need to go to the hospital, I'm fine. And then they had a rebound crash, whereas you're not seeing that so much with that diluted. I think that's
a good point. Yeah, I agree with that.
And to that point, I want to stress, and I think we've talked about it before, but if not, it's definitely worth repeating, is that the patients that are they're type 2 diabetics and they're on the medications for the oral hyperglycemic meds, if you take that medication once a day, we know it works for 24 hours. Those patients that are hypoglycemic on those meds, they need to come into the hospital because they're likely going to drop their blood sugar again. They need to be admitted. So if you come in, you're hypoglycemic, and I fixed it, and then you drop back down, I'm just admitting you to the hospital. You need to obs for 24 hours. We should not be signing those hypoglycemic patients off that are on the oral anti-hyperglycemic meds because they have a high likelihood that that's going to happen again.
Yeah, I think that helped a lot of providers. We talked about that in one of the CEs 1 month, I believe, about the different types of, if this is a type 1 and they're on insulin, or the shorter acting
versus long acting,
stuff like that. And it's very important to pay attention to that and talk to the patient. That's a great point.
And it's complicated. We've got very well educated people that don't understand that long acting Lantus insulin's okay to even give to a slightly hypoglycemic patient, because that medication's not going to go right now. It is the basal insulin. It's what we all have right now going on. We have our basal insulin there. That's what that Lantus is. And it gets complicated with that, with understanding how glucose gets processed through the body and how insulin interacts with all those processes.
Yeah. Mainly for you, Scott, it's Mountain Dew. How does that get processed?
Well,
pancreas is working overtime.
Yeah, right.
That's been working overtime for 20-some years, I would think.
At least. And I'm not as bad as I used to be. But that's...
I'm just teasing.
Yeah.
But no, those are good points, though. It's just... And it goes back to talking to your patient, trying to get that full picture. And I think it just goes back to meds. I think, we build the foundation in paramedic school, and then you get out in the field, and you should have a general foundation of what these meds are. No different than, what are some of the common blood thinners, right? That should be known by EMTs and paramedics, because that could differentiate a trauma activation.
Antiarrhythmics, rate control drugs.
Yeah, these are the things that we should start to see, and that's the same thing with diabetic medications.
Yep.
And if you don't know, hey, do you take one pill a day? Do you do a shot a day? There's really easy ways to kind of tailor that to your patient to get the information you back to see, hey, is this a short-term agent or is this a longer acting?
I do a shot with every meal. Okay, that's short acting.
Yes.
I do a shot a day. That's a longer acting. I do a shot
Or they may
a
do
week.
two, one in the morning, one in the
absolutely.
afternoon.
Yeah.
And we've been on those calls too, where the patient took the wrong one at night. They took their fast acting at night instead of their, and so they tank and again. So
it's just good to.
It's good to understand the drugs that your patients are taking. And I did some quick math here. The reason why D5 in the 100 bag that we have for mixing drugs doesn't work is you have about 1/5 the amount of glucose in that as compared to what's in your 250 bag. So you're giving them, I might run through that whole 100 mLs of fluid. I only give them 1/5 of the glucose that they needed.
Yeah,
they're not going to wake up.
And we have, and I think one of the biggest coaching points on that to all the providers out there, if you made that mistake and you're giving it and you're like, man, my patient's not waking up, I check another blood sugar, it's still low, they're still unresponsive. Well, evaluate your treatment actions.
Exactly.
It's that circle, identify, treat, reassess.
we call this trending.
Yeah,
I
called
keep hearing
trending.
this
I didn't
word,
want to say the trigger word.
And we have to trend.
And who's not had a diabetic that's was 32? You pushed an AMPA D50 on them and they just laughed at it.
Yeah,
and it went, or an AMPA D50 or a bag of D10. They got the full 25 grams. And it just wasn't enough.
Correct.
Right. My case was, I may have talked about this before. Nursing home messed up and gave 10 units of regular rather than the one prescribed. All right, and that was I did talk about this because I said it was the only time in my career somebody walked up and says, I screwed up, I need help. I got you. Right? And we were just standing on, it was a long time ago, so it was D50. But she just laughed at the first amp, right?
Yep.
I think we were going to talk
10
about
times a dose of what they're getting used to. They're going to need a lot of sugar to correct that.
Yeah, absolutely.
We were talking off camera a little while ago about being professionals in our career. We should be professionals and have professional equipment to use, like stethoscopes and such. I think also this goes in line with your glucoses. I've seen when I worked in the ER way back when, you get a squad that comes in and says their glucose is 120. And then we would take a glucose and it's like 15 or just says low. And it's like, so you have to remember where you're taking your blood. Don't pull them off your blood tubes. Don't grab it from venous blood. It's meant for capillary blood. And how often are you calibrating your meters? I think we've talked about that before, but just remember, if you're seeing no changes after giving an amp of D50 or 50 or 25, check your interventions, and this comes back to trending vitals.
Exactly. My data doesn't match what the patient's doing. Maybe reassess. Try a different finger.
Yeah. And I think
try a different glucometer if you have it.
Yeah, 100%. And then you'll catch that error. So if I hung that bag of D5 and I'm like, hey, I loop back through my circle, my blood sugar hasn't changed. What's going on? My treatment's not working. So did I hang the wrong bag or I hung the correct bag and they just need more of it?
Correct.
I need more. And I think your point
don't try
about
to take your AccuChecks off of a prosthetic either. It doesn't work.
Oh, God. That goes with your whole blood thing, too. A lot of people do that, and, it's really easy.
Quick look.
It takes you about 2.5 minutes if you actually open the manual to the glucometer, which I know most people don't do, but I'm a little bit of a nerd there because it'll just be like, well, it says high, right? So I call the ER and I'm like, my meter says high, doctor.
What does that mean?
So is that 500 or is that 10,000?
Correct. Yeah. What does that mean?
400 or 600? Commonly, they're 400 to 600.
Yeah.
Like 400. Okay. 600. It's pretty impressive.
Yeah.
But if it says high, it's above that. So what is it?
Yes. And I think that's also, it's an important documentation thing. It's an important item to pass along to the hospital for a report. Hey, my meter says high, and that means their sugar is greater than 600.
Yes.
And, I've started an IV, now I'm giving fluids because this patient's hydrated, right? So
and what an amazing thing that us as intermediates and paramedics can do to start giving fluid boluses before they encounter you, because we cut down how much ER stay time for you guys to do the same thing.
Yep.
It's just
you're starting the definitive treatment.
Right.
I'm going to obviously continue to work up, but if it's just high glucose and I just need to correct that, and they're 500 milliliters in of fluid already, great. I'm ahead a half hour at that point.
Yeah.
Going back to the number you get on your glucometer, make sure it matches your clinical presentation, right? I mean, how many times have we stabbed a finger, gotten a number, and you're like, no, let's.
This patient is not 33.
Give me your other hand. You good? You good? No,
I've said it 100 times. I know you guys said it 100 times. Treat your patient, not your equipment.
Yeah.
And if something's not looking right, it's probably not right.
Right.
Trust your patient.
I was working
Patient's
off.
drinking a Coke, and they're like, 33, huh?
Yeah.
I think too, with that, to Caleb's point and all of our points as well, is not everybody lives at
Excellent point.
98.6.
Excellent.
correct. It's not like that temp where this is your temperature and then your BGL is normally 70 to 120, and it's like, well, I have this patient and they're altered, but their blood sugar is 72, but the protocol says I treat it under 70, and it's like,
we treat symptomatic patients.
Correct. And I think that's one of those, there's the stop if they're following the protocol down, and I get to step B or C, and I'm like, oh, well, I can't treat that. No, you can treat that. We want you to critically think, why are they different? A lot of these patients even keep logs of their sugar. Yep. So if you go over there and it's like 220, 200, 180, it's like, okay, so at 70, that might be extremely low to them versus like your patient where 33 is low to them. Or
if you
ask
say,
the family.
Hey, it's 70, like, oh, that's really low for them. They're typically 160.
Bam.
Gotcha.
Yeah.
All right.
Yeah.
For some reason, don't know why. If I personally get down south of 80, I start feeling it. Right.
Yeah.
Again,
everybody's different.
That would be a classic normal finding in me, but for Scott, for some reason, it's woefully woefully insufficient.
Just need another 30 rack of dew. We'll keep this going.
A lot of what we talk about is paramedics diagnosing and treating, and you can't not use that word. We are literally diagnosing our patients in the field and treating to what we diagnose.
What we found, sure.
And it doesn't mean that that's going to be the end all, because you may see something completely different. But I've been fought on that quite a bit, where we're not supposed to be diagnosticians. That's not correct. We are. We have to be, because we're following a protocol in line with what we've diagnosed. And if we are in fear of our diagnosis, wait around, it'll change, right? But hopefully we're not doing that. Reach out to med control, reach out to your partner, and confide in each other and figure it out. But we are very much so diagnosticians, and we have to be. And that changed for me dramatically when we added the little blip in the protocol that said you can give a Denacard if you suspect this to see if you're right or not, and that was SVT. I was like, we are now using a medication to diagnose something. That's pretty cool. So
yeah.
I'll get off my soapbox.
I think that it's worth saying, and I wanted to say it earlier, and now's the perfect time, is that the protocol is the protocol, but it's written, a lot of things we put in protocol are chosen very specifically. Some things are specifically left broad and not specific. Some things are very specific. And sometimes it's just good general knowledge. If you have a 72 and you suspect it's hypoglycemia, and you want to call me. Hey, I got this guy, he's at 200, now he's at 70, he's not responsive. Can I give glucose? Yeah, go ahead and give that a try. That way, when you come into me, hey, I got his glucose up to 150, he's still not doing anything. Like, great, we've ruled out hypoglycemia as a cause of this. I can move on down the diagnostic line.
100%. And changes that, I think it changes that provider's thinking process there.
Absolutely,
like, if you get in that position, or we've all been in that position where you're like, oh, okay, I think it's this, and then this doesn't work.
Something,
and then now you
narrows it down past that or to it, and
process of elimination. And now I'm going to work a different angle. Then I'm going to work a different angle,
except for
we're trying to figure out the root cause,
which could be almost anything. I teach the medic students, and I know you do too, that we look at the top 5 that'll kill them first, and we start weaning it down.
Absolutely.
And by the time we get to the ER, we should have something pretty definitive, and 90% of the time, we're right on track.
Or you ruled out the life threat.
I should be able to tell you, here's what
This
it's
is
not.
what it's not.
Yep.
Right.
Yes.
Yeah.
Right. That belly pain here, it's not a STEMI. Here's my EKG that
Right.
shows it's not a
Yeah.
STEMI.
Yeah.
Yep.
And that rash
Here's
is
where
definitely
we're at.
varicella. So,
My unresponsive patient, it's not hypoglycemia. Right.
yeah.
At least you've ruled out the low-hanging fruit. Or in the case where you might say, I got a patient and he's glucose 65. Okay, we'll just give him some glucose. I'll be in there. Versus, no, it was 60. I corrected. It's now 150. He's still not responding. And as I'm trending vitals and he's becoming more bradycardic, I'm going to be in that room.
Sure. Yes.
Is different than I got a guy who's hypoglycemic. Right?
Yes. 100%.
Give him some glucose. I'll be in there when I can, as opposed to you're giving me critical information that I need to be in that room for that critical patient on arrival and be intervening and taking over the care that you guys started.
Yeah.
Yes.
Vitals.
Vitals.
They're vital for a
Trending.
reason.
How important are vitals, and how important more so is it to trend my vitals? If I come to the ER with one set of vitals on a 20-minute transport, is that acceptable to you?
Absolutely not.
Yeah.
That shouldn't be acceptable to anybody.
To anybody. And I think that going back to the most basic of thought patterns, 5 minutes, every 5 minutes for criticals, every 10 to 15 for nons. In a 20-minute transport, that's still at least 2 to 3 sets.
Well,
In
yes. What you should be doing on even your most basic of ankle pain, right? You're going to get your initial set of vitals, as you should, and then you should get another set of vitals before you transfer care, if not to just prove that everything remains stable.
Correct. And pre and post any intervention for the most part.
Absolutely.
If I'm going to give you a saline bolus, I should take vitals before I've done it. That way you know where he's at afterwards. What do you consider vital signs at the bare minimum?
Ooh, you're going to trigger me now.
One soapbox to the next.
Yeah, exactly. So, vital signs are going to be blood pressure, pulse, respirations, SpO2, and I throw glucose in there. Glucose should definitely be part of your vital signs.
I throw capnography in there too. It's so easy
Absolutely.
to get anymore.
And again, we talked about steroids and breathing problems, and that's a large amount of patients we see are respiratory.
Sure, of course.
Yeah.
And having an end title on there gives me a lot of information. If it's low, if it's high, if it's normal.
When I started in the career, we were not diagnosing or reading 12 leads. We were lucky to do 3 leads, right?
I wasn't taught it.
Exactly.
It was short.
It was-
Do you
very.
still carry around your stone tablets that you learned with?
This wasn't that long ago. This is 2004-ish, right? So what I'm saying now is, yeah, we are doing all that, but what can we add to this?
We're still using the same curriculum today.
We now have what's called a capnograph.
Yeah.
What can we see on that we're seeing on EKGs is just as prevalent. So, I mean, I'm sure you can vouch for that. Reading a capnograph is important, and it tells you a lot.
It does tell me a lot. And what comes to my mind is I had a sick patient who was, a squad brought him to me. He was trach dependent, so you couldn't throw on the inline capnograph. And they didn't do that. He was a difficult patient, and when I drew my blood gas, I found he was hypercarbic. Well, that explains a lot of things that's going on. I got a trach-dependent guy that's hypercarbic that I've got to intervene, and I have to actually replace his trach on him. We didn't have the right size, so I had to put a 6.0 ET tube through his neck to be able to ventilate it and put him on a vent. Now, the squad that brought me that patient had a 15-minute transport time. You could throw on capnography and realize, oh, this is what's going on. This is why the patient's altered. I shouldn't have to wait for my blood gas to come back to say, oh, he's hypercarbic.
Correct.
And I think, too, further to your point, and I don't want to be misconstrued or misunderstood because I am very pro manual blood pressure for my first set of vitals. I mean, I like the machines and pro machines as well, but I liked manual vital signs initially, or at least for the pressure. But we're using, and I'm just looking in between Scott and Caleb just because there's a LifePak 15 sitting right there. You can program that to your agency and exactly what you want. So like at our agency, it's going to take a blood pressure every 10 minutes.
Oh, now I got to cross off my note here.
Unless
Making myself.
unless you want to change it. But I mean, ideally, that is an information center that you're putting so much information in just from the use of the events buttons that's going to drag into your documentation. Absolutely. Plus, I could set up all my vitals trending to automatically be running in the background. So, you know, if you're pressed for time during a transport, this is going to free your hands up a little bit as well. So I have my monitor giving me my CATMO, my EKG, all these different types of things are automatically running while I'm providing more treatment on my patient. I can look at it, use it as a reference tool, look at them, compare where am I at, but it's automatically working for me in the background. So we need to utilize that.
Let me build.
Super easy to set up.
Let me say one thing real quick beforehand. You said manual blood pressure is important, the first one. Some people are going to fight me on this comment, but this particular machine has a complete guesstimate on that blood pressure. The only true number on there is going to be your map pressure.
Yeah, 100%.
So we have to disagree.
That's not this machine. That's any automatic blood pressure.
Any NIB cuff. 100%. I agree. And that's
if I'm looking at map pressures, if I have an LVAD patient, 100%. I mean, that's going to work great for me.
Turn that off. just trend the maps. I mean, that's what it's.
Yeah, and that's fine.
So
that's also built into the protocol in multiple areas too.
Now, if I just so happen to get a manual blood pressure of 130/80, and this is showing 128/83, I'm happy. Yeah. I'm happy. We're close.
Correct.
Which it probably will, but just remember, it's a guess.
Yeah, and if I get a map north of 65, I'm usually pretty happy too.
Yeah.
All right, I'm gonna ask a dumb question.
Okay,
it's typical.
I know. you should see me in the department.
Doctors.
On the LifePak 15s, and it's cycling a blood pressure, does it show you what the current pressure is inside the cuff?
Yes.
Okay. So what I do in the emergency department, if I don't like that blood pressure...
Feel a pulse as it's going down?
Yeah.
What? And you watch the number, and when you see the pulse come back, you know that that's a systolic. It's not perfect, but it gives you an estimate.
It gives you an estimate.
Oh, I'm seeing 130s, and I have a pulse back. I know their systolic is 130. I'm less concerned.
It's a semi-automated, palpated blood pressure. It's what you just did, right?
Yep. Yeah. Please, just on a side note, use the appropriate size cuff. And then if you're watching the machine go, up to its 160 and then come down and then go up to 180 and then come down and then go back up to 100, 200, stop. You're not doing anything for the patient. It's not finding something he doesn't want. It's causing a lot of pain. You are tourniqueting the patient's arm. Just take it off and do a manual. Or feel a pulse, like you said, and then just go with it over palp.
I find it easier and quicker to do that because, honestly, for you guys, it's quicker for you guys to do a manual blood pressure than it is for me in the emergency department because then we got to have someone go find the actual hand pump to go do it, right? It's a thing.
But I totally agree with the,
Has anybody seen those stuff with physiognomometer?
Totally agree with you guys.
Then they walk in, anyone have ears?
Yes, we all have ears. And then they turn them the wrong way. They're facing this way.
But, yeah, manual blood pressures, obviously, if your machine isn't, if it's giving you stupid numbers, question marks, asterisks, whatever it's going to give you, right? Transition to manual, you should have a reference to validate the machine. And then once you have the machine running, you've touched on this, you can even configure the NIBP interval on the fly, right?
Yes,
and
change it.
And kind of my sales pitch to people is it's worth the time. Let's say on a trauma or post arrest or something like that. It's worth the time to do the extra couple knob turns because you are not that good at time management that you're going to be like 2 minutes NIBP. 2 minutes NIBP.
Yeah, and just looking over your machine and hearing it run should trigger you that you're at that mark.
I've watched trends where people were doing that, right? And there's like this big bunch of, I hit it a bunch of times in, 37, and then there's like 9 minutes, and then it's, that patient deserves better. Mm-hmm. Set it down to 2 minutes. That way, every time you glance over at it, it's good, new, fresh physiological data. Just let the machine do the work for you. Don't try to be smarter than the machine. The other pieces, and you kind of touched on the information from the machine when it goes into our report, that's a little bit more durable than if I put it in manually, right? Because I could skew those numbers intentionally or unintentionally when I put it in my chart. But if I import that, right, and it's just ripping it straight across,
it's there.
And if somebody really wants to, put the screws to you from you're bullshitting those numbers, these are Jesus vitals or whatever, you're making this stuff up, then you just like nope, and it's all part of the,
tells you the source part of it came from.
It tells you the import.
Absolutely.
And so is your EKG picture, so is your 12 lead picture.
Correct.
It's all encompassing to show you that.
So
how important is it to put that on your event pages as opposed to just narrative though?
So it turns out there's a bullet point there. Thanks for just jumping right down there.
Before we jump into
on that.
the event.
Well played segue. Right.
If you're importing data, though, from the monitor, please be aware what that data is and make sure it's valid data.
Yeah.
So
You can kill.
you make sure you review the data and you're not importing like, oh, they were tachycardic, hypotensive, and then a minute later you actually have real vital signs that show a normal patient. Delete the erroneous data so that way you have a nice clean report from it.
Correct.
We can always go back and look at that data.
Correct.
Yeah.
That was the.
And it's explainable that way too, yeah, because we had a squad. You could set your VFib alarm or VTAC alarm off and on, right? They go down a bumpy road, and it's like VTAC alarm, and it's like sinus rhythm, VTAC alarm.
And you get that a lot with capnography. You'll get apnea alarms.
Yeah, you get the apnea alarm. So that's a great point. You gotta clean up the data. It's not that you're not hiding it in any way, shape, or form, but it was artifact that caused the machine to interpret it that way. It's just not accurate.
And you want an accurate report.
Correct.
Of course. I would hope. Before we move on to the charting and the event log, which you're, was so nicely set us up for, and then nobody bit. I think we need to throw our shameless plug out there to Stryker, who sent us this demonstrator, LifePak 15, for the sole and only purpose of being here as our wall hanger, right?
Yeah.
Jason Roberts, our local rep, sourced this from Stryker Corporate, so we had things like this to talk to current equipment. So thank you, Jason, and thank you, Stryker, for sending us this. Don't you think for 1 second we didn't try to put a battery in it and see if it was a legit piece of machinery? It is not, but it's still perfect for demonstration. So thank you so much.
Thanks.
Otherwise, it was like, we got a free monitor. But
events are important.
Event log, yes.
Yeah.
And they've come into play a lot with cases that I review because I do have squads that we have first responders that show up and then followed by another transport agency, which is not unique to my squads. It happens all across the country. And we've had issues in the past that I've had to address with them when times don't match up. So if you're using the monitor and everyone's using essentially, we've standardized upon the LifePak 15 here for UH. So they all use the same monitor. Whenever they are syncing data to the cloud or whatever or transmitting, it synchronizes its time. So the best thing you have that's going to match time wise is your monitor. So if you're doing vital signs on your monitor, if you're marking events on your monitor, and then another agency shows up and hooks up their monitor, those times are going to be near second perfect. And you're not going to rely on a third party, whether that's dispatch center A and dispatch center B. Are those times going to match? And I've had issues with that very recently in the past that we've addressed, that the monitor is actually what's going to be saving us to say like, oh yeah, well it makes times that this data makes more sense on the monitor.
Yeah, no, that's a great point. And they auto update every night, so they're the same time.
Yeah, they're all synced.
Let's just talk about one of those cases, which I saw in the biweekly email, is ketamine was given by the first responding ALS agency and then transported by another ALS agency, right? And that discrepancy teased out there, and there was a whole email chain about, well, this is actually the same patient, right? And it's actually the same patient, but these times they didn't jive, right? So, yeah, that's super important. Likewise, when we're running reports on medications, right?
That's huge.
We can't report on the narrative, right? AI is getting there quickly, right? At some point, I think maybe we'll just be able to do the narrative, but
yeah. But if you're like, man, I did my third IO for this year, and I've only ever put it in the narrative. You did no IOs.
You did no IOs when we run the report, or when we run a med usage on something, right? So it's super important that the line item, the event log, gets put in. Everybody's like, well, it seems like people either push a bunch of stuff into the event log and then write a limited narrative,
or a giant narrative,
and forget the event log, and you need a kind of a balance of both, right?
The way that I do my narratives is it's a summary, right? I don't need to say like I pushed 10 I'll try to leave you guys. I did 125 milligrams of Solumedrol IV. I don't need to put that in my narrative because my event log says that. Correct. I gave Solumedrol. Right. That's what I have to say. Just a general statement.
Yeah.
I know the date and the time and whoever did it and what route and
That's
all
right
that.
here.
All that
That's right
details in your event.
Yes.
That's what we can report off of. That's what we need to be able to use when we're looking at drug utilizations, which we're doing right now with one of our medications. Or if we're talking about equipment utilization, when we had our CPAP episode and we're talking about how many CPAP circuits do we use. If we just put down in the narrative, I put them on CPAP, you're not going to get credit for that, and we might adjust our practices or what our decision, our protocol is based upon what's happening in an event log. If it's not in the event log, it essentially doesn't happen for us at a macro scale, and we need to be able to know that information to be able to provide the best care we can.
And on the backside of that too, not only just for data gathering, for protocol, changes, evaluations. This might be something you want to discuss with either the MS coordinator or whoever handles your billing at your agency too. That was one of the things we did was we sat down with our billing company and said, because we had an uneven balance for a little while, and it's great now. And the way they explained it was, here's all your event logs, and that narrative needs to support why did you do those events.
Why you did that.
That's an easiest way. That's probably one of the easiest ways I've seen that delivery. Hey, I did all these things in the event log. This is why that patient needed all of them. This is why I believe they needed all of them and how to help them. So you do need a balance on that.
Yeah, and like just to sum up on what you said before, if we're doing a lot of something and it's not working, this is a great time for us to revisit us using this within the system. So documentation is huge on that, and we can't see it unless it's in the event log.
Yeah.
That is Ferroni trying to get me to do the outro because we're at an hour for this episode. So we're gonna wrap this up as the talking points for this extra July. Look at that, I haven't got it right.
It is July.
I haven't got it right for this extra July, and then we have now the second order leftovers that we're going to come back and we have one more fifth Monday this year. So the rest of the stuff on our list here we're gonna hammer out in a different episode, and we'll give I think it's October. Don't quote me on that. I think it's October. Yeah. So we'll have the second order leftovers for you on in October, that fifth Monday in October. So you're not bored and you don't forget about us and on your Mondays. We want to hijack your feed every Monday with something, right? And of course, if you like the content, please like us on Facebook, follow us on YouTube. The channel is UHEMSI, and not only is there podcast stuff there's some other training videos and some other stuff that's jammed in there as well. And I think if you want to get, like we talked about at the beginning of the show, and thanks for bringing that up, is prehospitalparadigm.com is going to be all of this content, whether the typewritten stuff, whether it's the podcast, all of the UH foam ed stuff, so the medical director Mondays or the pharmacy Fridays, and all that educational. We've got some docs that are going to start soon putting in great critical analysis of great cases, and we plan on doing some equipment reviews and some stuff like that. All that will be available at prehospitalparadigm.com. So please check that out in addition to all of our other resources. So we'll see you guys with the remaining leftovers in a couple of months.
Make sure you give your steroids when appropriate.
Yes.
Don't be afraid of them, and make sure you choose the right concentration of your dextrose.